Okay, you started recording. So I don't see your screen.
Oh, okay.
Oh, there you go. It popped back up.
Okay, cool.
Hi.
Are
you go.
we able? Have we started recording?
Yep, I have.
Okay, cool. Just making sure.
Okay.
All right. Good evening, everybody. I see we have a few people in the audience. I have some more guests who will probably be rolling in a few minutes or so. But tonight I'm going to be presenting on a paper on interstitial lung diseases. So I'm interested in pulmonary medicine, much to the chagrin of most of my classmates, because they cannot stand the lungs and anything about them. But I just find them so interesting because they have such a wide range of immunological, inflammatory, oncologic properties that really require you to synthesize a vast amount of information in order to understand what's going on in a patient. So I think the lungs are a very underrated but very cool organ. Tonight I'm going to be talking about this paper that I found on immunologicatory treatments that are used for interstitial lung diseases. It was authored by these four pulmonologists up in Canada, published in the Therapeutic Advances in Respiratory Diseases, volume 16, back in 2022. And I'm just going to highlight some of the features of the articles. It really talks about a little bit of background, the treatments that they discuss, how they approach the treatment, and give ways that we can possibly optimize that treatment to effectively treat interstitial lung diseases. So with that, I'm going to get started on my paper, and I'm going to start with a little introduction on interstitial lung diseases. They are a group of pulmonary pathologies characterized by inflammation and fibrosis of the alveolar walls. It's thought to occur because of some kind of internal or environmental insult that causes a lot of havoc within those alveolar walls, leads to an inflammatory response, which leads to the recruitment of immune cells, macrophages, T cells, neutrophils, usually leads to the formation of granulomas, which are large aggregates of those cells. And they normally secrete substances that lead to the walling off or the destruction of a pathogen. But in the case of ILDs, these substances lead to damages within the tissue. And because the tissue is so damaged faster than what can be regenerated by normal tissue regeneration, the lungs heal themselves by depositing collagen into the walls. And so all that scar tissue within those walls lead to trouble because the lung is not able to inflate like the elastic balloon that it's supposed to be, thereby decreasing your FVC. And all that collagen within the walls leads to a dysfunction in the diffusion of gases between a capillary and an alveolus, which leads to a decrease in your DLCO. So impaired expansion, impaired gas exchange. There are various types of interstitial diseases. I have a non-exhaustive list right here. The prototypical one, the one that people talk about mostly, is idiopathic pulmonary fibrosis. This one is especially characterized by widespread fibrosis of the lung tissue and ultimately has a worse prognosis than all the other ones usually. I know two people who've had idiopathic pulmonary fibrosis. One of them is my aunt, who's been battling it for about 8 years. She's now on oxygen, and she's taking methylprednisolone, which is a stronger version of prednisone. And she's doing okay, but it has been progressively worsened over the last 8 years. The second person I've seen is a patient I met at Grady back in October, a young man about 24 years old who has been dealing with IPF for about 8 years or so. His trigger was thought to be an external one from marijuana joints that he'd been smoking since he was like 15 or 16. He would go through these cycles of smoking, having coughing fits, stopping, but then restarting, having more coughing fits, stopping, then restarting. All that until now he's on oxygen constantly, and he takes a lot of agents to control his ILD. So just as a side, just be careful what you do to your body. You don't know how it's going to react. There are several ILDs that are not idiopathic pulmonary fibrosis. These are called secondary ILDs because they have an underlying pathology that's usually a systemic or localized to the lungs, which leads to the ILD. There are several causes like connective tissue disorders, rheumatoid arthritis, sarcoidosis, vasculitides like granulomatosis with polyangiitis. And as I mentioned, this is a completely non-exhaustive list. These are 3 CTs that I found on Radiopedia of different ILDs. The one in the middle here, this one is idiopathic pulmonary fibrosis in a very severe stage. You can see all this fibrosis. And in the periphery of the lung, you can see this honeycombing, which is exactly what it sounds like. You can see these pockets surrounded by fibrosis that looks like a little honeycomb. Over here on the right, this one is rheumatoid arthritis. You can also see some honeycombing out in the periphery, not nearly as much fibrosis here in the central part of the lung. And over on the left, this one is sarcoidosis. It's a little hard to appreciate here, but there's some hilar lymphadenopathy, a little bit of fibrosis in the lung fields, but not nearly as severe as these two here. And because there are different ILDs with different underlying pathologies, it is crucial to diagnose the ILDs accurately, because that can lead to a perfect or optimal tailoring of agents used to target those ILDs. Different agents respond differently to different diseases. And because you want to know the accuracy, you can tailor those treatments to that specific disease, maximizing the benefits from those agents and minimizing harm from having a progressively worsening ILD that's not responsive, and minimizing harm from side effects of the treatments, because these treatments can have some nasty side effects. That we're going to get into the therapies that the authors mentioned. And there are only 6 of them, so you don't have to have your eyes glazed over for too long. And if you're not familiar with some of these drugs, some of the MD1 or MD2 people who are on here, you're going to be intimately familiar with them by the time you're at the end of your 3rd year. So the first one is the first-line treatment for any systemic anti-inflammatory process, and that is ibuprofen. No, I'm kidding. It's corticosteroids. The one that they usually use is prednisone. These work by decreasing a lot of immunological proteins that are involved in inflammatory processes, prostaglandins, leukotrienes, cytokines, and they also decrease the proliferation of T cells. In some ILDs, such as these ones listed here, corticosteroids are very effective. They can lead to a reversal of symptoms and even a full recovery. But corticosteroids are avoided in systemic sclerosis ILDs. This is because steroids can precipitate something called a sclerodermal renal crisis, which, breaking it down, is just a rapidly progressive renal failure that can occur with people with systemic sclerosis. It accounts for about half the mortality associated with this disease. So because of that, you want to avoid anything that can trigger this. So steroids are not used first. Instead, for systemic sclerosis ILDs, the first-line treatment is this one here, mycophenolate mofetil. This is an interesting one. It works by decreasing the activity of this enzyme called inosine monophosphate dehydrogenase. If you remember back from your biochemistry, to create purines, adenine and guanine, there are 2 pathways. One is a de novo pathway, the other is a salvage pathway. De novo is building them from scratch. Salvage is recycling. Lymphocytes do not have a salvage pathway. They can only make purines from the de novo pathway. IMP dehydrogenase is part of the de novo pathway. So when that's frozen, lymphocytes cannot make new guanine. And because of that, these lymphocytes are typically just stopped right in the middle of DNA synthesis, and then they can die. I don't know what just happened to my screen. Hold on. Okay, are y'all able to still see this?
Yes.
Thank you. And mycophenolate is the first-line steroid-sparing agent and first-line for systemic sclerosis, as I mentioned. Next treatment is azathioprine. This one is also an agent that decreases the synthesis of purines, but this time it works on adenine and guanine. It is a second line for sarcoidosis and has shown improvement in these ILDs according to papers that the authors have found. This next one here, methotrexate, I have a fondness for this one because back in late August, early September, I was doing a little independent literature search to see if antifolate agents like methotrexate have an increased prevalence of causing anemic symptoms in Black women who are much more prone to developing anemia. So far, the results are a bit mixed, but I can talk about that a little bit more in the future. But as an antifolate, methotrexate decreases the synthesis of purines and thymine, and it's very effective in stopping the growth of rapidly proliferating tissues like lymphocytes. Also, second line for sarcoidosis, delays the detection of rheumatoid arthritis-related ILDs. Next one, big guy here, cyclophosphamide. It's an immunosuppressant and a chemotherapeutic agent. It's an alkylating agent, so it works with the DNA to disrupt how it's synthesized and pretty much just disrupts the integrity of the DNA molecule. It is the main treatment for vasculitides that have these anti-neutrophilic cytoplasmic antibodies, or ANCA. So granulomatosis with polyangiitis related ILDs respond well to cyclophosphamide. The big dangerous thing about this one is it is known for its bladder toxicity. It can metabolize into an agent that can cause irritation of the bladder mucosa, ultimately leading to a hemorrhagic cystitis or even a squamous cell carcinoma of the bladder. As such, it is not used for long-term treatment. It is used with a lot of saline, and it has to be administered with an agent called Mesna, which pretty much disrupts how that agent interferes with the mucosa. Last agent that they mention is rituximab. Monoclonal antibody targets CD20 on B cells, which has shown improvement in these two ILDs here. Now have been talked about, we're going to discuss how the authors would approach having the treatments administered to patients with ILDs. The usual approach is starting with prednisone, unless there are contraindications. You wait till there's some kind of stabilization or improvement in symptoms. Then when you see that improvement, you would add a second agent, such as one of those other 5 that I mentioned. And when you do that, you gradually taper down the prednisone. But you would use the other agents first when the presentation is severe, such that oxygen is required, if there's been a rapid progression of symptoms, or if for some reason steroids are contraindicated, like you have a patient with Cushing syndrome or diabetes or a systemic fungal infection or systemic sclerosis-related ILDs, as I mentioned. And it's important when you're tapering agents, you do so gradually, because if you do so too fast, you can have an exacerbation of symptoms or even a rapid progression of symptoms that are already present. And those are antithetical to what we try to do in medicine. Other approaches include the addition of a prophylaxis against pneumocystis jirovecii pneumonia, PCP. Because you're introducing immunosuppressants, this normally harmless fungus can evade immune detection and cause a necrotizing pneumonia and can kill you. So naturally, we want to add some kind of medication that would lead to prophylaxis, usually in the form of trimethoprim sulfamethoxazole, also called Bactrim, or pentamidine. Similar agents that they would give to AIDS patients when their CD4 counts drop below 200. Also, because some of these agents, especially steroids, can lead to osteopenia, wearing down of the bone, it is vital to provide some kind of bone health protection. This will come in the form of supplements of vitamin D and calcium and a pharmacologic agent such as a bisphosphonate. And of course, surveillance and patient education are key to managing any chronic process. So continuing to do so as you see patients with ILDs is critical. The authors also mentioned some approaches to the agents, or to some of the agents specifically. For mycophenolate, they suggest avoiding antacids and cholestyramine. That would decrease the GI absorption, so the patient who's taken them wouldn't see the full benefits. For azathioprine, they recommend genetic profiling to find people who metabolize this agent more slowly. This is not a widely used routine, but the authors proposed this because everyone metabolizes drugs differently. So people who metabolize it more slowly might see either an increase in benefit or an increase in side effects. For cyclophosphamide, they recommend using an IV route when administering it because this leads to less toxicity to the white blood cells and the gonads. Total dose should be less than 20 grams, reduce the incidence of bladder toxicity. As I mentioned before, administer normal saline before and after treatment to flush out some of that nasty toxin that can come and irritate the bladder wall, and administer this agent called Mesna, which would interfere with that little metabolite. Disease progression with ILDs can be monitored in the following ways. If the doctor or the pulmonologist notices a worsening of FVC or DLCO, that will be a surefire way to tell that the ILD is getting worse. You can look at the chest CT and look at the baseline from a while ago, see if there's worsening fibrosis. That's also another way to tell whether it's worsening. There's this test called the 6-minute walking test, and it sounds exactly like what it is. You would monitor a patient's O2 saturation, heart rate, and respiratory rate at rest while they're walking for 6 minutes and after they're done walking. It's an independent predictor of mortality in patients with interstitial lung disease. Also, patient-reported outcomes are important in determining disease progression. If a patient feels like they're getting worse despite being given all these treatments, then that is a surefire way to tell that something is not really happening like it's supposed to be. For particularly bad fibrosing ILDs, there may come to a point where a pulmonologist or whoever's managing this disease may add an antifibrotic agent, such as these here below. But this is only at a very advanced stage because these agents are known to have some bad side effects. They are collagen antagonists, and we require collagen for our skin, our hair, our eyes, and our bones, so that might lead to thinning of all of those agents. So we typically use those as a next to last resort if the fibrosis is really bad. Now, if any of you are still awake or doing absolutely anything else, you can be happy because I'm getting to my conclusion right here. To summarize, immunomodulatory therapies are very successful in the treatment of ILDs, but it is critical to diagnostically or have diagnostic accuracy when identifying the ILD, just to tailor the treatment to have safe and effective treatment of the diseases. There is one thing that the authors would like is to clarify the optimal timing of these treatments and the proper sequence of which agents should be used for a specific ILD. My thoughts about the paper. I thought it was really good. I thought it was very well organized, very comprehensive. It broke things down very well, and it provided some evidence of like the effectiveness of each of the agents. But I do think that it should have provided a bit more on the efficacy of certain agents. Like when you saw on the slides when I said like, for example, rituximab has shown improvement in systemic sclerosis related ILDs, usually just based on one paper. So I think finding, say, 2 or more articles to support this improvement from this drug, that would make it a little bit more robust. I also think that it was comprehensive. It was a little, compact. I think they could have done better by splitting the ILDs differently and having, say, 2 or 3 different papers on the therapeutic effectiveness of some of these agents on different ILDs. But overall, I thought it was very thorough, very well organized. Now I'm really getting to my end right here. I want to thank the Journal Club for inviting me to speak. I want to thank all the guests who came just to listen. This was a lot of fun, and I was really looking forward to it, especially since the past couple of weeks have been a little bit crazy outside of school. It just allowed me to be eccentric and just get away from the humdrum of every day. So if you have any questions, my email address is here. Despite my appearance, I'm actually very approachable, and I love answering questions, and I'm very amenable to that. And with that, I'm going to turn it back over to the Journal Club. Thank you once again. Oh, these are my references.
Yeah, and thank you, Jerald. I just wanted to take a minute. If anybody had any questions about the presentation for Jerald, now's the time. Okay. No worries. All right. Well, thank you again, Jerald. You were the only presenter we had today, so we're going to wrap up here. Really great presentation. For everybody else, our next meeting is going to be on June 27th. If you're interested in presenting yourself, we're going to send out another form that will kind of give you the information as to how to register to do that. Other than that, everybody, we're all good. Have a good summer. Hope you guys are being productive, or if you're not being productive, hope you have fun. All right.
Thanks, Joe.
Thank you. Good job,
Good job.
Ben Jones.